Your patient's septic. You've run the fluids appropriately, aggressively. The map still isn't where it needs to be. The resident says, let's start a pressor. And the question that actually matters isn't which drug, it's which lever and why this one. If you've been through HEMO 1 through 3, you already know the two levers. Cardiac output, the pump, and systemic vascular resistance, the nozzle. Vasoactive drugs are just tools that push on one of those two levers or both. And once you know which receptor each drug is hitting, the whole vasoactive pharmacy stops being a list to memorize and turns into a small, logical map. This is Vaso 1, the first stop in the vasoactive series. It sits directly on top of HEMO 1 through 3. We're not reteaching MAP or cardiac output or SVR here. We're mapping drug classes onto the levers you already know. Quick reminder of the frame. MAP equals cardiac output times SVR. Pressors tighten the nozzle. They raise SVR. Inotropes help the pump. They raise cardiac output. Some drugs do both because they hit receptors on both sides of the equation at once. Which brings me to the real skill of the lesson. Before you ever say a drug name, ask which lever failed. Pause and predict. Your septic patient is warm, flushed, bounding pulses, still hypotensive after fluids. Pause it. Is this a pump problem or a nozzle problem? The nozzle. Warm and bounding means flow is fine, maybe even elevated. The vessels are dilated. That's distributive shock, and it's a pressor problem, not a fluid or inotrope problem. So here's receptor logic underneath every vasoactive drug you'll ever give. None of this is foreign biology, by the way. It's the same axis your body already runs. When your blood pressure drops, your own baroreflex triggers norepinephrine release onto the same receptors before any bag ever gets hung. Alpha-1 receptors sit on the vessels. Activate them, and intracellular calcium rises in smooth muscle. The vessel constricts. SVR goes up. That's the nozzle receptor. Beta-1 receptors sit on the heart. Activate them, and CAMP rises in the myocardium. Contractility and the heart both climb. Cardiac output goes up. That's the pump receptor. Beta-2 receptors sit on vessels too, in certain beds, but activating them does the opposite of alpha-1. It vasodilates, partially undergoing whatever alpha-1 is doing at the same time. Vasopressin works on a completely different pathway. V1 receptors, also on the vessels, use the same calcium mechanism as alpha-1, but on a separate, non-adrenergic receptor, which matters most when a patient's adrenergic receptors are worn out from prolonged catecholamine exposure. V2 receptors are a kidney story, not a pressure story. They drive water retention, relevant to fluid balance, not SVR. Dopaminergic receptors, concentrated in the renal and splenic vessels, are the basis of the old renal-dose dopamine teaching. Low-dose dopamine selectively vasodilating the kidney. It's a durable teaching point. It is not well supported by outcome data, and you should hold it loosely. Milrinone skips the adrenergic system entirely. It blocks the enzyme that breaks down CAMP. So CAMP rises in both the heart and the vessels at once. More contractility, less resistance, and the same time. That's why it's called an inodilator. And Angiotensin II acts on AT1 receptors, a third pathway, fully independent of adrenergic and vasopressin systems, reserved for vasodilatory shock that isn't responding to the first two. Pearl, every one of these receptors maps to exactly one lever, SVR, cardiac output, or both. Learn the receptor, and you've learned the drug's job. No dose required. Put names on the map. Norepinephrine hits alpha-1 heavily and beta-1 modestly. mostly nozzle, a little pump, and it's a first-line vasopressor in septic and other distributive shock. Epinephrine hits alpha 1, beta 1, and beta 2 all at meaningful levels. It's an agent you'll see added on top of norepinephrine, behind vasopressin in most sepsis pathways, and it's first line in anaphylaxis and cardiac arrest for reasons beyond today's scope. Phenylephrine is pure alpha 1, nozzle only, no pump effect, which is exactly why it can drop cardiac output through reflex bradycardia, even as the pressure number goes up. Pitfall. Vasopressor doesn't mean pure vasoconstrictor. Norepinephrine and epinephrine both carry real beta-1 activity. Confusing pressor with inotrope or assuming any drug can only pull one lever is the single most common mistake at this level. Vasopressin and Angiotensin II are the non-adrenergic adjuncts, nozzle only, reserved for when the adrenergic agents alone aren't enough. Dobutamine and Milrinone sit on the pump side, inotropes for a failing heart, with Milrinone adding some vasodilation as an inodilator. Dopamine straddles both, dose-dependently, which is exactly why norepinephrine has largely replaced it as the default first-line agent. Pause and predict. Post-MI. Low cardiac output, SVR normal to high, pump or nozzle, and pressor or inotrope. Pump. The heart's failing, not the vessels. That's an inotrope, dobutamine or Milrinone, not a pressor. One more pattern worth carrying forward. In mixed or refractory shock, when one agent stops being enough, practice tends to add a second drug on a different non-adrenergic receptor, vasopressin or angiotensin II, rather than just pushing the first drug higher. Stacking two agents on the same adrenergic pathway compounds the same receptor fatigue that got you here in the first place. Exam tip. If a question describes a drug added on top of norepinephrine, look for the receptor, not just the class. Vasopressin, V1, and angiotensin II, AT1, are non-adrenergic by design. At the bedside. Any alpha-1 active infusion, norepinephrine, phenylephrine, vasopressin, and dopamine, is an extravasation risk. Central access is the traditional standard. Watch the site and watch the rhythm on anything with beta activity. Doses and exact access and titration protocols live in the per agent lessons. One picture, the hose, pump, and nozzle, with receptors branching off each side, alpha 1 and V1 and AT1 on the nozzle, beta 1 on the pump, beta 2 and Milrinone doing a bit of both. Name the failed lever, then the receptor tells you the drug family. Dose comes later. 3 questions. 1. A distributive shock patient is hypotensive after fluids. Which lever and which drug is first? 2. Why can phenylephrine lower cardiac output even while raising blood pressure? 3. Give one receptor level reason to add vasopressin instead of just raising norepinephrine dose. Answers are pinned in the comment. Next up, norepinephrine itself, in full, the receptor detail, the titration logic, and yes, the doses. That's VASO 2. I'll see you there. There's a free one-page study guide linked below. Hit subscribe and you'll catch the next one. I'm building these in order so they stack.